Thank you very much, Maher, for that wonderful introduction. So our first lecture is from Professor Shamir Mehta. Shamir qualified from King's College in London in 1996 and completed his Masters in Clinical Dentistry in Fixed and Removable Prosthodontics in 2005. He is a partner in 2 mixed dental practices in Northwest London, the Deputy Programme Director of the MSc in Aesthetic Dentistry at King's College London, the Senior Clinical Lecturer Advisor Fitness to Practice for the General Dental Council, and the researcher at Radboud UMC, Nijmegen, and the Netherlands. He has gained publications in numerous peer-reviewed journals and is the co-author of 2 textbooks, written several book chapters, a panel member for the European Expert Consensus Panel on Severe Tooth Wear, and part of the Radboud Tooth Wear Project Group. He is also an examiner for King's College London, a member of the FGDP UK Academy, a facilitator for FFGDP, and a reviewer at the Centre for Advanced Practice Health Education England, which is HEE. The lecture is on restoration of the worn dentition, an evidence-based approach. Thank you.
Thank you, Andrew. Can I just confirm that you can see the slide?
Yes, we can.
Yeah. Okay, great. Thank you. My talk today is on the restoration of the worn dentition, taking an evidence-based approach. So my interest in tooth wear started about 20 years ago, and that led to the publication of a 4-part series in the BDJ in 2012. And on the back of that, I was invited to a European consensus meeting in 2016 in Nijmegen, Netherlands. And from that emerged a consensus statement, which was published in the Journal of Adhesive Dentistry. And for anyone interested in tooth wear management, this is something that I would strongly recommend as a reading source. And throughout this lecture today, I'll be making recurrent reference to this paper. So I'm a general dentist, and I suspect many of you attending this meeting today are too. And in my experience, and I'm sure it's not I'm sure it's the same with you as well, I'm seeing more and more cases of tooth wear year on year. To give you an example, these were just some cases I saw just before the start of the pandemic, within a relatively short period of time. And I guess the question we ask ourselves is, why is this? This is quite obvious when we look at the epidemiology of tooth wear. And I've highlighted a number of studies here, although there are many, many. The 2009 UK Adult Dental Health Survey, which reported signs of anterior tooth wear amongst 77% of a sample of about 5,500 dentate adults. Now, in the UK, we have an aging population, and it would seem logical with people holding their teeth into later years that we're going to see signs of tooth wear. But the problem of tooth wear is not limited to older adults. Other studies have shown high prevalence rates of about 30% on the buccal and lingual surfaces amongst younger European adults, with the UK having very high levels, or the highest levels amongst the countries included in this study, which was probably related to the UK population's preference for spicy foods. But again, the problem is not limited to adults only. Global prevalence rates have shown an estimated global prevalence of about 30 to 50% of tooth wear amongst the deciduous dentition. And again, this is probably related to lifestyle change. Late 1990s, the consumption of fizzy drinks, which are largely contributory to sort of erosive wear, has gone up by about 7-fold, with a large amount of consumption amongst a sort of teenage year of patients that we see. Tooth wear is different from caries and periodontal disease, and just out of interest, it's the 3rd most common form of oral disease after caries and periodontal disease. But it's different in that tooth wear takes place as part of the natural aging process, whereas the other two conditions don't. And therefore, this makes this a lot more challenging, where there's a need to define physiological wear or distinguish that from what's not physiological, with physiological wear being normal age-related wear of teeth. And some studies have done some measurements in terms of what that would be. In contrast, we have pathological wear, and pathology, usually the term implies some form of disease. And this was defined in the European consensus meeting as tooth wear causing pain or discomfort, functional problems, or deterioration in aesthetic appearance, which if progressing may rise to undesirable implications of increasing complexity and is atypical for the age of the patient. So that distinguishes pathological wear from physiological wear. But we then have patients who have tooth wear with no pathology, no symptoms, etc. And you will see signs of tooth wear. And for this, as part of the consensus meeting, the term severe tooth wear was defined, which was tooth wear with substantial loss of tooth structure, with significant loss with 1/3 or more of the clinical crown. And this description is quite helpful when we're looking at sort of indices that are used for scoring and grading. So let's just have a look at a few examples, because it's quite important to understand what we're talking about as tooth wear. This is an example of pathological but not severe tooth wear with an adolescent who we would all agree is experienced clinicians that there isn't signs of severe wear, but this patient had symptoms of sensitivity. Here we've got a case of an 83-year-old male patient with severe tooth wear, but is not pathological. Patient has got no symptoms, no concerns whatsoever. And it's in this level of air, one could perhaps say is typical for age. But then you can have tooth wear which is pathological and severe. And here is an example with quite advanced wear, where the wear present is also causing symptoms and concerns for the patient. So using these descriptions, a flow diagram was presented as part of this consensus statement. And I found this very useful. Certainly when I was a younger dentist, I would get very confused about what to do with these sorts of patients. And in essence, where you've examined the patient, and if you deem the wear to be physiological, then nothing really further needs to be done. If the type of tooth wear is pathological and or severe, then there would be the need to carry out risk assessment, identify the etiological factors, document the level of wear present, and that would usually be followed by an appropriate preventive program with counseling and monitoring. And with that in place, you would then undertake an assessment for the need for restorative rehabilitation if the wear is a concern for the patient and or the clinician. And today's lecture is going to largely focus on the restorative side with sort of a reference to the evidence base. But before we get to that, as I said, an important thing is for patients with tooth wear to try and identify the etiology. Now, we know that tooth wear has a multifactorial etiology, and evidence has shown that erosive factors are involved in about 80% of the cases. And lots of different sort of classifications of the etiology has been described. In a recent textbook, myself and my co-authors have described 4 primary mechanisms. One is mechanical intrinsic tooth wear, which is tooth wear which takes place as a result of chewing or bruxism, what we often call attrition. The other is mechanical extrinsic tooth wear, which is due to factors other than chewing and or bruxism, often referred to as abrasion. Chemical intrinsic tooth wear, which is a result of gastric acid, erosion. And chemical extrinsic dental tooth wear as a result of an acidic diet, also known as erosion. And having identified what the likely cause is, you would use that information to give a targeted preventive treatment plan. Now, I'm not going to go into that because that's a lecture in itself, but if you've got interest in that, we recently published a paper in the Update about the prevention of wear, taking an evidence-based approach. In fact, with doing my research, when writing this, I came across quite a lot of interesting observations. And this is certainly worth a read if you've got an interest in knowing more about the prevention of tooth wear. Now, as I said, once you've identified the etiology and provided a preventive plan, the next thing is going to be to monitor the progression of the disease to see if your preventive plan is effective or not, and to assess the rate of progression. This can usually be done by chairside evaluation, typically using an index. The basic erosive wear examination is one that's quite a simple and practical one to use. Then there's the tooth wear index of Smith and Knight, and one which is used quite a bit in the Netherlands is a tooth wear evaluation system. But there are over 110 different types of tooth wear indices, so a lot to choose from, unfortunately. Sometimes it can be quite difficult to use an index to score every single tooth and surface with the patient in the chair. So you can take study models, gypsum casts, and undertake assessments using an index, or even making a sort of a silicon index, as we do when we sort of make provisional crowns or composite buildups, to see if you can assess levels of wear using that. Nowadays, with more and more of us using intraoral scanners, you can obtain digital models and use an index using that. And you know, I suspect in the future, sort of subtraction software will be available where you'll be able to actually measure levels of wear at particular points, reference points on a tooth, and that will help with the treatment planning. And of course, there's the option of using photographs, and these are a good sort of a visual aid and can be used alongside indices as well. So there are various different tools that can be used to monitor wear. And in general, when you see a patient with more severe forms of wear, after giving the preventive plan, it's a good idea to undertake some kind of observation before diving into restorative treatment, because if you don't manage to control the etiology very well, it's highly likely that the restorative plan will fail prematurely. There are some exceptions. For example, a patient with very rapid wear from an eating disorder, etc., that might sort of fast track things along. But in general, a period of observation, which also allows you to develop a relationship with the patient and explain complex restorative plans, as you'll see in a minute, and ensure that they understand what you're proposing. But there are going to be some cases where simply throwing fluoride and providing splints is not going to be enough, and where active restorative intervention is going to be needed. And generally, these are where there might be aesthetic concerns, functional concerns with phonetics and chewing, for instance, or patients complaining of discomfort, or, as I said before, where the level of wear is very aggressive and a concern for the patient, clinician, or both. Now, before I sort of dive into the sort of clinical aspect and showing some cases, I thought I'd just discuss the philosophy for managing wear cases. Now, there are two ways, if you like, to skin the cat. One is taking a conventional approach, which usually involves a prescription of multiple units of crowns and onlays. The other is an additive or minimally invasive approach. And especially now with the availability of predictable materials that we can bond to effectively glue back what has been lost. And I'm just going to explore these two. And as I've got at the bottom, they're not mutually exclusive. It's in many cases, you end up using a combination. But if we look at the conventional, the traditional way of treating wear cases restoratively, to place a crown on a tooth, we know for a tooth-colored crown, we're looking at studies from Edelhoff and Sorensen that there may be the need to remove 60 to 70% of hard tissue volume to accommodate a restoration. Now, when we're looking at treating a worn tooth, that really doesn't make sense. In contrast, the additive process is minimally invasive. With conventional crown work, we know that there are risks of pulp tissue damage, estimated to be 10 to 20% in the literature. Again, with the minimally invasive approach, this is likely to be minimal. We also know that preparing crowns is irreversible in terms of having done the preparation. And we know that some patients, unfortunately, at times do not adapt to complex occlusal and aesthetic changes. And therefore, that becomes a minefield in itself. The use of a minimally invasive technique gives some sort of contingency planning in that it's not reversible as such, but you may be able to remove what you've placed with minimum damage or minimal damage, if you like. But of course, it's important to gain consent for whatever you do. Conventional crowns require copious amounts of coronal tissue for retention resistance. Of course, for adhesive work, there's a need for a good quantity and quality of enamel. With conventional work, we again are looking at provisional temporary crowns, which adds to the cost and the complexity. For adhesive work, there's a need for good moisture control. And in relation to the matter of cost, we estimate that the treatment using conventional crowns is substantially more expensive than going in with a sort of a minimally invasive approach. And the use of materials like composite, as you'll see from my cases, allows you to almost give your patients, almost test drive the changes that you're proposing in a sort of a more minimally invasive, a more predictable way. And we know that you can adjust composite by taking some away or bonding some more material to it to sort of help tweak whatever you've provided to fine tune your restorative prescription. And this is kind of this view, this philosophy is embraced in the consensus statement, whereby effectively, if we look at the second paragraph, restorative treatment should be as conservative as possible, employing minimally invasive strategies, applying a dynamic restorative concept. And whatever we do, whether it may be conventional or adhesive, of course, emphasis is on the importance of attaining informed consent and ensuring the patient understands the full risks, the benefits, prognosis, et cetera, et cetera. So for just sort of descriptive purposes, I'm going to divide the wear case into localized and generalized case. So here we have the first clinical case. It's a chap that I saw a couple of years back in his early 40s. You can see that he's got sort of moderate to severe wear, affecting largely his anterior teeth, both upper and lower. And he had concerns with the aesthetic appearance. Now, if we're looking at the restoration of this, essentially, we've got three approaches we can take. One would be to restore in the intercuspal position when the teeth are maximally meshed together. Now, of course, we're not going to restore teeth which are not worn down, but if we were to restore the anterior teeth, we would find that back teeth no longer come together unless we place conventional crowns. So restoring in the intercuspal position, usually for wear cases, is not possible unless the patient may have an anterior open bite or a posterior open bite, for instance. In some patients, there is a slide between the maximum intercuspal position and the first point of contact in centric relation, when the mandible is manipulated into centric relation into a more distal position, or what we call the distalization of the mandible. And sometimes that creates enough space to allow you to put your materials in, to bond materials into place without opening the bite and creating a new position which is not physiological. So of course, if we're taking this reorganized sort of approach, as we see in point 2, is within the physiological parameters. So that would be another approach. You would accept my word, in this particular case, that room wasn't available. But that kind of emphasizes the need to take mounted study casts to allow you to study the occlusion with the casts mounted in centric relation without the effect of the neuromuscular reflexes, the tongue, the cheeks, so on and so forth. The third approach, given that we want to treat this in a minimally invasive way, was to basically put the restorations proud of the bite, or what we call in supra-occlusion, utilizing what's commonly known as the Dahl concept or relative axial movement. And that is what was done in this particular case. So here we have a wax up, and the planning of the wax up is a series of lectures in itself. But to just point out to you, we've waxed up the teeth according to the patient's aesthetic requirements and what we think will be a stable occlusal position. I'll come back to that later on. But where you can see with the arrow, there is a space there between the back teeth once the wax up is being done. And the idea with this Dahl approach would be that in time, those back teeth will come together through the process of condylar repositioning, through some intrusion of the anterior dentoalveolar segments, and extrusion of the posterior segments. And this case, which is not just limited to localized anterior wear, there are some back teeth with wear, the lower left first molar. Whilst we've opened the bite, we have the opportunity to restore that in a minimally invasive way, and you will see that in a minute. So here we have the case, the wax up was done, and a silicone key was made from the wax up, which you can see at the top of the screen, a bit like when you do your class 4 anterior composite restorations. And that key, which copied the occlusal prescription on the wax up, is being used to layer composite in a minimally invasive way. And with this particular case, there was no tooth subtraction or no macroscopic tooth subtraction using any burrs beforehand. And what we find here is that we've got the opportunity to provide an aesthetic occlusal prescription by minimal intervention using some of the really good materials that we have available. As I said, that there was a lower left first molar where there was wear, and I took the opportunity to simply prepare a margin, and a gold hat was bonded into place. And there was a crown on the other side, which was simply replaced with leaking margins. I took the opportunity to build the lower anterior teeth in exactly the same way, other than the deciduous tooth, which was discussed at detail beforehand, where the patient didn't want to have it extracted, and simply a sort of a composite mask has been applied there. And here is the same case three months after. And what we can see is that the back teeth have come together on the lower images, and the occlusion tested using shim stock. And we can see the presence of even centric stops all the way around. And we can see on the top right the presence of a canine guided occlusion. And these are the sort of occlusal endpoints that we would be looking at with these sort of cases, which helps us to sort of establish this going to be stability. But the thing I want you to focus on is that the teeth have come back together after a period of 3 months. And this technique, this Dahl approach, which some of you may have heard about, it's not limited to the use of resin composite. You can use all sorts of other materials. In this case, which in fact I treated, these were placed in 2006 and reviewed several years later. In this case, I've used metal palatal shims. These are made from nickel chromium, similar to what can be used for crown and bridge alloys. You can use type 3 or type 4 gold as well, and I'll talk about that a little bit more later on. And this gives a sort of a robust alternative where the restorations can be fabricated at quite a thin sort of thickness, if you like, and it can give quite a durable, predictable outcome. You notice there that I've got some cingulum rests. Nowadays, we wouldn't usually provide those. One of the risks with this approach is obviously the dulling of the teeth, which you can see, but therefore the use of this would be really limited to where the pattern of wear is more on the palatal side with minimal incisal edge loss. And there is some evidence, a study by Knoll, which I've put at the bottom, of a good success rate of roughly 90%, where they looked at 201 metal palatal veneers observed for a period of just under 5 years. So this can be another approach to the management. And again, these can be put proud of the bite. And this metal is similar to what you would use for your resin bonded bridges, your Maryland bridges, etc. So let's look at the Dahl concept, as I said, often known as relative axial movement or occlusal adaptation. This is nothing new. It was developed in the mid-70s, where the team used a removable cobalt chrome appliance on patients with wear. And essentially this appliance was an anterior bite platform with cingulum areas, and it resulted in increasing the vertical dimension of the occlusion by about 2 to 3 millimeters. The appliance was worn continually for several months until the back teeth came back together again. And the space created at the front by the back teeth coming together could then be utilized to place restorations in without effectively drilling away or taking away any further tooth tissue where obviously a lot of injury had already taken place. And what they reported, or what has been reported, is that with these sorts of cases, occlusal context usually re-established within 4 to 6 months, but it can take a lot longer, up to 2 years. And as I said before, the process involves a combination of initial condylar repositioning, followed by intrusive 40% and extrusive 60% movements of the dentoalveolar segments. The overall evidence seems to suggest a success rate of 94 to 100% with the use of this DAL approach, irrespective of age and gender. And one of the things that we now know, and you notice that my cases involve the use of bonded restorations, is that we've kind of moved away as a profession from using removable appliances, largely because of issues with compliance. And the evolution was to move away from that to then move on to the metallic type restorations that I showed, which were cemented into place, to now using composite, which offers an aesthetic approach. And we also know from the evidence that we have that in applying restorations in this way, with careful case selection, that adverse effects, pulpal conditions, periodontal disease, TMJ problems, etc., apical problems usually are not observed. But the key thing with success with this is careful case selection. There are going to be some cases where putting restorations in supraocclusion and expecting a predictable outcome, it may not happen. And these are cases with limited eruptive potential. And these are cases where you would think very, very strongly about taking this approach where it may fail. And these are ones where there may be an anterior open bite, posterior open bite, patients with bony exostosis, where there might be signs of ankylosis, such as with an implant retained restoration, where there might be fixed bridge work with sort of either end, not a cantilever design, and in cases of severe class 3 malocclusion. So these are the sort of cases, if you come across patients like this, you've got to think very carefully about using this treatment approach. There are also some pre-existing conditions which may contraindicate placement. And this might be if your patient has already got TMJ-related problems, there's a risk of making things worse. If there's active periodontal disease, where there might be endodontic treatment to the teeth, or where the opposing tooth may be heavily restored, where placing an opposing restoration in supraocclusion may increase the risk of a fracture, for instance, or where the patient may have had orthodontic treatment in the past, where disengaging the occlusion for prolonged periods of time may lead to relapse. So there are certain sort of alarm factors that need to be considered when sort of prescribing this form of treatment as well. Now, much of the evidence that's available, or in fact, all of the evidence, as far as I'm aware, in relation to tooth wear, all relates to the placement of dial restorations at anterior teeth. There is some work ongoing for posterior restorations, and we hope to publish that in due course. But what I'd like to sort of bring to your attention is a study which I did with my colleagues in 2014, where we utilized the DAL approach of putting restorations proud for the minimally invasive management of cracked tooth syndrome. Now, at the outset, for someone who hasn't heard this concept, it would sound quite wacky, putting in a restoration proud on a tooth with a crack. But without going into too much details, what I wanted to tell you or discuss or share with you are the outcomes of this study, where we found putting a single restoration in supraocclusion at the posterior teeth amongst a sample of 140 patients, where obviously we applied careful case selection, as I've discussed. We found that in 97% of our sample, the posterior teeth reestablished contact within 3 months, and out of interest, it was 97% successful for the minimally invasive diagnosis and management of cracked tooth syndrome. But this might be a paper that you might be interested in. It was published in the Journal of Dentistry in 2014. So the DAL concept is by no means limited to anterior teeth and no means limited to tooth wear management. You may also use it to place in restorations in supraocclusion, such as resin bonded bridges provided with minimal intervention. So let's move along to generalized tooth wear. Now, traditionally, sort of prosthodontic teaching, patients with generalized tooth wear were put in one of three categories based on this proposal from Turner and his colleague. Category 1 patients are where there's excessive wear with the loss of vertical dimension of occlusion. Now, these are cases where we know that our patients normally have a freeway space of 2 to 4 millimeters. These are cases where the rate of wear is usually very high and exceeds that of the compensation. You notice with the other case that certainly that patient with wear wasn't born with teeth like that, but you notice that his teeth were making contact. And that happens because of this dentoalveolar compensation, where due to growth of the dentoalveolar segments and cementum deposition, the teeth will want to maintain patent occlusal context. But for these category 1 patients, the level of wear is such that it exceeds the rate of dentoalveolar compensation. So the freeway space is likely to be bigger than your 4 millimeters. Category 2 are ones where there isn't that loss of vertical dimension, but there may be space available elsewhere. And I'll show you some examples. Category 3 is where there is excessive wear with no space available anywhere. And those are the most difficult ones that we come across. So if we look at category 1, if I show you an example, this is a chap that I saw a couple of years back again, in his late 30s, and he had a generalized wear with a love of fizzy drinks and a highly stressful life. And doing a basic assessment, he had a 6 millimeter freeway space. And that kind of told me that I've got room available there to place materials in a minimally invasive way, in an additive way, to add back to those worn surfaces without the risk of violating that physiological freeway space. So again, some diagnostic work was done, some wax ups at the increased OVD. And those wax ups were indexed in the anterior. And I usually start off by restoring the anterior dentition first, establishing the required aesthetics and the anterior guidance, and ensuring that I've got enough room for the back restoration. So the front teeth were built up using composite in a minimally invasive way, layering to try and get a good aesthetic result. And having done that, you can see on the top left, on the bottom left where the retractor is present, that there is room available now, created by the building up of those anterior teeth. And that room gives me some space, or the space that I need, to put in an occlusal veneer, an occlusal onlay with minimal tooth reduction. And here we see I've prepared some finishing margins on the right-hand side. And the same has been done on the left-hand side. Now, a lot of people ask me about sort of provisionalization. What I tend to do is to use the wax up to produce an index and then just use a provisional crown and bridge material. I think in this case, it was ProTemp. The restorations are linked, which is obviously not ideal, but there's enough space there to get a interproximal brush through. And these were cemented in using zinc polycarboxylate. Now, obviously, material selection is very important. And I know that the ceramics are evolving all the time. I don't have much experience with zirconia, but I have used Emax. But I'm a bit nervous about using Emax on posterior teeth. There's a lot of experts in the tooth wear field are. I'm quite happy to use them on premolars, but not as much on molars, and we'll discuss that in a minute. My preference for restoring molars is using gold onlays. And if you're going to use gold onlays like this, this is a type 3, it's important to ensure that the fit surface is oxidized by doing heat treatment or doing electroplating, because gold is a precious metal with a low surface energy and will not bond well to resins such as Panavia unless that surface is appropriately treated. And just going back to that, we know that with the use of gold onlays, with the very limited evidence available, the use of these restorations in a study done by Harpal Channa, good success rates, 90% were reported over a period of 5 years. And that's my own sort of, if you like, clinical experience, does give quite a predictable approach. And here we see these onlays that were all bonded on one occasion. And here we see the post-operative result, centric stops all the way around. where the centric occlusion is coincident with the centric relation. There's canine-guided disclusion. And that's what we refer to as the mutually protected occlusal scheme, with shared contacts between the front teeth and protrusion where the back teeth separate. Now, the other type, category 2, is where there won't be space in the vertical dimension, but space may be available elsewhere. And this is, again, when you manipulate your patient into centric relation by the distalization of the mandible, you may well find, and you'll see that in the next slide, that or in the slide after that, some space will be available, and you can use that space to restore that patient in a physiological position. Traditionally, the approach was to provide these patients with a removable occlusal scheme with the new height and the mechanics of the mutually protected occlusal scheme by fitting them with a Michigan appliance or a Tanner appliance, a hard, full coverage acrylic splint. And these would usually be worn for a period of 1 to 3 months all the time, other than when eating, to ascertain whether the patient can tolerate these changes that you're proposing. This was a case that I did, again, quite a few years ago. I unfortunately don't have the picture of the splint in situ, but he was given a Michigan upper splint to wear, got along with it very well. And we decided to restore all of these teeth indirectly in one visit. So we had some indirect composite overlays made for the anterior teeth where they were wear, and posterior gold onlays that were used to include the premolars, which was his preference. Of course, what can now be done is you can have your gold hat made slightly sort of thinner on the buccal face and actually bond, mask the gold using masking techniques and bond some composite across should you wish. But again, that's a lecture in itself. But this was a case where the patient was given the splint, got along with it well, and those occlusal features were copied across into the definitive restorations. This is another case of a category 2, and this patient had wear in his late 50s. And as I said, my sort of usual approach is to have some mounted casts on a semi-adjustable articulator. And this, you can see that there's some room available when the mandible is distalized to give me space to bond my material into without increasing his occlusal vertical dimension into a position which is not physiological. Wax up was done, and the idea is that we've got an endpoint, which is the mutually protective occlusal scheme, as I said, with even centric stops, posterior tooth separation on protrusion and excursion, with canine guidance and shared contacts and protrusion. And as with the other cases, the wax up was used to produce a silicon key, which was used to apply composite in a layered fashion, doing the upper teeth and the lower teeth. And then in this particular case, in fact, what I forgot to mention, why I'm showing you this case, what we've realized is tolerance with splints is not very good. A lot of patients don't want to wear them. They want to have the treatment done sooner. There's a cost of the appliance, so on and so forth. What we now know with using materials such as composite, why not bond a Michigan splint into place effectively, if you like, by building the teeth up using composite to establish the same occlusal endpoint as you would do with a splint. And that's the approach that was done here. And what I started to do is to build the back teeth using composite as well. And normally you'd keep the composite restorations quite flat, as you'll see in the next picture. But what I found is that I got towards the premolars, and I'm a general dentist like many of you, and we come across the same difficulties. The patient was getting along very well. And then I decided to just put some gold hats on the back teeth, because it's getting quite difficult to keep this patient's mouth open for prolonged periods of time. And here we see the end point. The worn posterior teeth have been restored with a combination of flat posterior composite restorations with centric stops, and gold hats were placed at the molar teeth. But there's nothing stopping you from restoring all of the teeth using composite and eventually substituting that composite for a more durable, more robust, more expensive material once you know that the patient has adapted to the complex changes that you're proposing. This is the third category, and these are cases where there's no room at all, and these are the sort of patients that you kind of hope don't walk through your door very often because they are very, very difficult to treat. This was a case, again, saw 12 years ago. This was in fact a family friend, and it's always difficult turning away family friends, I'm sure you're aware. This patient didn't want to wear a splint. There was no room elsewhere. Traditionally, these cases would be treated using approaches such as crown lengthening and conventional crown work. But you and I probably both know that, if we're going to prepare those lower teeth that you see there for crown work, the likelihood is that we'll be, visualizing the pulp. And the approach now, and the approach that I took, certainly in the Netherlands where I do research, is to kind of do away with this traditional category 1, 2, 3 approach, but to use composite to just build these teeth up. And we know that the tolerance is usually pretty good with this. And that's what was done here. With the patient's consent, the teeth were built up just using direct composite at the front teeth. And what I did at the back teeth was I had some indirect composite onlays made, and these were cemented into place. And it was really a way of seeing if this patient could sort of adapt to the planned occlusal aesthetic changes. This was done a long while back, and materials are a lot better than what was available then. Now, at the outset, knowing that the forces at the molars are 9 times higher than at the anterior teeth, and about twice that at the premolar teeth, and this was one of those patients who could probably damage a golf ball if you gave one to him. Knowing that, and I went through the consent process very carefully, at the back of my mind, I knew that the composite restorations that were going to go in the back teeth were not going to last as long as the front teeth. But as I said, this approach gave me the opportunity to evaluate whether he could tolerate these changes. And in the least, putting this material across those surfaces helped to protect them. And this is pretty much what I found. If you look at the lower picture, within about 2 years, and the lower picture was taken in 2011, the composite started to wear. And this is what I had expected. But now, knowing that the patient can accept what I've done, and he's happy, he's able to chew without any problems, etc., I can use conventional crown restorations by simply cutting back the composites and using techniques such as a customized guidance table to copy that scheme into a crown restoration, which otherwise, if it's incorrect, can be very difficult to modify where you've cut back a lot of tooth tissue. And therefore, the use of composite is not mutually exclusive. You may use it to trial out occlusal aesthetic changes, and you may use these sorts of restorations where you've kind of satisfied yourself that the patient is able to adapt to what you've done, but the patient or you want something more durable there without having to deal with the repairs needed for composite, and we'll discuss that in a minute. So what's the evidence base? Now, up to now, I've spoken a lot about composite, and unfortunately, the evidence for the treatment, the restorative treatment of tooth wear in terms of materials and techniques really relates to the use of direct resin composite. There are sporadic studies about using, palatal veneers, etc., metal veneers, but most of the available evidence relates to the use of composite. And the use of composite, and you've seen that obviously I favor that approach, and it's what's recommended in the consensus statement. It gives an aesthetic option. It's minimally invasive, well tolerated, can use it diagnostically, so on and so forth. However, it does rely on a good level of operator skill and the presence of a good quantity and quality of enamel. So let's have a glance at some of these studies. And there are about 15 of these studies published to date. And I've picked out a few because a majority of these studies are short-term, sort of 3-year performance data with relatively small sample sizes. But I picked out a few which I thought were interesting. Study done by Milosevic and Burnside. Sample had over 1,000 restorations. It's an 8-year prospective study, and if memory serves correct, with an observation time of about 3 or 4 years, mean observation time. And they reported an overall failure rate of 7%. And it just as a layperson, I would think 7% for 1,000 restorations sounds pretty good. Study done by my colleague at King's, David Bartlett, they looked at 251 restorations placed over a period of 4 years, which were monitored, I think, observed for a period of about 11 to 12 months. And they reported a good success rate of 83%, bearing in mind that short term, but signs of chipping or fracture were seen in 63% of the patients included, with at least one or more failure. And the message to take home here is the first study that the clinicians were experienced consultants. The second study, treatment was provided by postgraduate students. And the message here is, or two of the things that were highlighted is the importance of operator skill, especially with doing these composite buildups, as well as the influence of the etiology of the wear present. Study done by the Eastman Group, Ghulam Ali and colleagues, and I've picked out this study because it's one which is looking at the DAL approach. And they had a sample of 283 restorations placed in supraocclusion with a 10-year follow-up with a mean follow time of 5.8 years. And again, they found 90% signs of major and minor failure, typically wear, marginal discoloration, so on and so forth. What was interesting was the survival rate of replaced restorations was slightly lower. And the thought was that this might be amongst those teeth where there's less enamel available and a greater reliance on dentine bonding. And we know, despite advances with dentine bonding, enamel bonding is obviously gold standard and far more predictable. They also had some indirect restorations, indirect composites, and there wasn't that much difference. But what they did note was high levels of success with class 3 incisor relationships compared to class 1 or class 2 div 2. And that would be logical that if you look at class 2 div 2, you're going to do composite buildups on the anterior teeth. Those are likely to be exposed to quite high levels of tensile shear strains, and that may account for sort of a higher failure rate. So looking at the occlusion beforehand is very, very, very important. And again, you need to discuss these risks with your patients and how that can be managed. The fourth study, and I say this with an air of caution, is in my opinion, the most relevant one, not because I'm the author of it, but this was published a couple of months ago in the Journal of Dentistry, and I've highlighted some bits of the abstract, which I think warrant some discussion. This study included the largest number of direct restorations, direct composite restorations, or 1,269, with the longest observation period with any other study of 62.4 months, up to 5.5 years. And what we found is that the number of catastrophic failures where the restoration just couldn't be repaired was very small, only amongst 2.3 of the entire sample. The other failures were amenable to repair, where you could repair the composite by doing a bit of revision bonding or a bit of polishing. And what we reported were overall annual failure rates of the anterior dentition of 2.2% per year, and of the posterior restorations of 2.9% per year. Effectively, the posterior restorations are more likely to display signs of failure, but these are more likely to be of the variety where they can still be repaired to give service. And what we found, the risks of failure at the molar teeth was twice as high at the premolars, and that would make sense given the higher levels of loading, as I discussed before. What we also found in a follow-up study, and I haven't included this here, which was also published in the Journal of Dentistry in July of this year, is that there's a significant association with how tall you make the restorations, how high you make them, with the survival. Essentially, the thicker, the taller you make them, the better they survive, and that would probably relate to the increase in sort of the compressional strength that you get with a material such as composite as you make it thicker. And the take-home message is, when you're going to put these, you do need to apply as much material as possible, respecting the sort of biological, aesthetic, functional parameters. Of course, you don't want restorations which look unsightly or with massive overhangs. But composite can offer a very good outcome if you got good patient selection and appropriate operator skill. And in this particular study, all 5 operators were skilled with adhesive dentistry protocols. So when you're looking to prescribe these restorations to patients, composite, you have to give your patients a proper discussion that these materials do require a lot of maintenance, debonding, chipping, fracture, wear and tear, discoloration will happen, and that's to be expected. And to try and help manage that, these patients will require routine monitoring and routine maintenance. And going back to the occlusion, one of the things that I focus on quite a bit is ensuring that canine guidance stays in place, which helps to protect the other restorations. And I ensure that the patients are seen on a periodic basis. And if there's any early signs of wear, especially at those canines, which are taking the bulk of the hits, that's adequately managed. I haven't spoken much about crowns or ceramics, and to be honest with you, there's very little evidence available. There is a study which was published by Milosevic, again 6-7 years ago. They looked at the performance of 161 zirconia crowns for the treatment of severe anterior tooth wear, with a failure rate of 15.5%, with a mean follow-up period of 72 months. Failures were largely due to debonds or minor delamination chips, so on and so forth. And there were some factors where there were higher risks of failure, such as edge-to-edge relationships. But what we do know with crowns, for the limited data that we have for wear studies, is that crowns do perform better in the short to medium terms, in terms of minor failures, than composite does. However, when crowns fail, the failure is usually catastrophic, and that was shown in a study done by Smells many years back. And when it's catastrophic, it's often the tooth has gone non-vital, or the core is fractured, leaving you with a root stump. Essentially, the tooth has reached the end of the line. Now, if we go back to where the lecture started, we're seeing more and more wear and tear with younger patients. And we need to think very carefully about how we manage them, especially with going in with highly invasive treatment protocols. We don't have, as I said, we don't have extensive data on the performance of crowns for tooth wear, but taking a more sort of a global snapshot, the study done by UK colleague Trevor Burke, they looked at restoration survival, and there were they looked at data for 3 million crowns placed on 1.2 million patients and 3 million resin composite restorations. Now, these are not exclusively on wear patients. I need to stress that. What they found was the time to next intervention for the crowns. 52% survived at 15 years, but with the fewest number of interventions. But when they failed badly. In contrast with composite, well, the survival rates were a lot less, with the need for a lot more interventions, but 83% of those teeth restored with composite survive without the need for extraction. So in conclusion, when you see a patient where it's really important to ensure you go through the processes, the prevention, the monitoring, and if you're going to restoratively manage these cases, where possible, the emphasis would be to take a minimally invasive approach, which gives you the opportunity to make some adjustments, to try and achieve the occlusal aesthetic endpoint, which the patient is satisfied with. And you can use more durable materials once you reach that stage by using techniques to predictably copy those sort of occlusal aesthetic features, using ceramics, using alloys, et cetera, So I think that's probably it from me. I thank you very much for taking the time for your attention and listening to my presentation.
Thank you very much, Shamir. I'm aware that we're a little bit running over at the moment. So what I've asked is that people can email Knightsbridge Academy with any questions for you, and they will facilitate them if that's okay.
That's fine. Thank you.
Thank you very much for your time. And please